Welcome. Hey, I'm glad that you could join me today. We're going to talk about the brain and the neurobiology of addiction. A little background for me. I'm the medical director here. I've worked here for the past 16 years. I'm an internal medicine doctor, and then 16 years ago shifted into full-time addiction medicine. In my own life, I didn't have any addiction in my own family, not one of my personal struggles. And so for me, I was a well-trained internal medicine doctor, but I didn't understand anything about addiction. And that's going to be the purpose of today. So from my background, trained internal medicine, UT Southwestern Medical School in Dallas, and then internal medicine at Baylor in Dallas. And so for example, back in the 1980s, long time ago for most of you in the audience, but back in the 1980s, I was a big Dallas Mavericks basketball fan. So the Dallas Mavericks had this guy named Roy Tarpley who played for the Mavericks. He was a phenomenal basketball player. His salary was phenomenal in the late 80s. He was making almost $5 million a year. I was making $14,300 a year as an internal medicine resident. I would have loved his salary and to play basketball as a career, but when Roy Tarpley came to the Mavericks, he was already struggling with addiction. So in the NBA at that point in time, they had a 3 strikes you're out policy. He had 2 strikes against him for violating the NBA substance use policy when he came to the Dallas Mavericks. He was 6th man of the year, either the first or second year in the Mavericks, which means he was the best non-starter. He had this phenomenal salary. It's in season. He's being drug screened because of his previous usage. And he uses and gets kicked out of the NBA. And that was mind-blowing for me. The concept that somebody would give up a $5 million a year salary was going to be one of the best starters in the NBA, and he gets kicked out of the NBA. And I'm just thinking that man is a non-intelligent person who would do that. I go into practice, general internal medicine. I take care of gastrointestinal hemorrhages, severe liver disease, horrific infectious complications from IV drug use, cocaine-mediated heart attacks. I have people who have a heart attack and in the hospital, they're injecting cocaine into their IV catheter right after a heart attack. And I'm just like, I don't get it. I don't understand it. That's the purpose of today, is sort of what's going on. And so for those of you who don't have that internal struggle, and then for some of you in the audience who are struggling with addiction, to give you a better idea of what's going on, that's the purpose of today. So there's going to be 2 parts of this lecture. We'll do the first part now, and then the second part a little bit later. So I want to start off with this image of the brain. So if you look at this image of the brain, this is a sagittal or sideways view. So it's like we've cut straight through this direction and we're looking. And as you look at that imagery, on the outside, you can see this edge. That's called the cortex. And that's where all high-level function happens. So when I talk about high-level function, if we look at the back part of that, what's called the posterior part, we can see the cerebellum where it says coordination, the visual cortex. That's where we process vision, so the entire back part of my head is responsible for that. Heaven forbid if I took a small caliber gunshot wound to the back of my head, but it just damaged that part of my cortex, I don't die from that. There's nothing key for survival in that part of my brain. I would lose balance, coordination, vision. We go up a little bit higher in the brain, and in this part of the brain we can see where it says movement and sensation. That part of the brain is very sensitive to stroke. So probably most people in here have seen somebody who's half paralyzed, or what we call hemiparetic, arm in a brace, leg potentially walking like with a 4-point cane. If there's not swelling or hemorrhage from that, people don't die, nothing key for survival. We then get into the front part of the brain, and if you look at this imagery in the front, you can see in that little blue area that says judgment, that part of the brain is what's called the prefrontal cortex. That's where impulse control, judgment, reasoning, and it's a little more complex than this imagery that you're looking at. But then in front of that, you can see this very large portion, and here, the human brain is very highly developed. So if you think about the rest of the animal kingdom, we're the only animal that has a forehead. So if you think about it, a dog, a cat, a chimpanzee, a dolphin, whatever, everybody else's skulls go right back above their eyes. But humans, we have this this frontal area, this forehead. That's because we have this very highly developed frontal lobe. So the frontal lobe is where all of our complex individuality, personality, all the stuff that makes you uniquely you from a personality standpoint, that all lives in the frontal lobe. A brilliant neurosurgeon back in the early part of the 19th century, we had no significant drugs for mental illness. He began doing animal studies and felt that he had the surgical solution for mental illness. He actually won the Nobel Prize for that procedure. It was called the frontal lobotomy, and some of you, everybody in here has heard of that, where they went in and they actually just surgically cut out part of the frontal lobe. Nothing key for survival. It was a disaster, actually, surgery. But, for example, Rose Kennedy of the Kennedy clan, Ted Kennedy, JFK's sister, had a frontal lobotomy for her mental illness. This kind of depersonalized, no personality, very flat, but again, nothing key for survival. So you've heard me say that, nothing key for survival, because if we leave the cortex, the outside rim, and we move into the center area. So in the center area of that brain, you can see two different areas highlighted. One is memory pathways, but also in purple is called the reward pathway. Now the reward pathway, right there in the mid part of our brain, that's the epicenter for addiction. So when I say epicenter, that's where all of the classic drugs of addiction work. That's where alcohol works. That's where cannabis works. That's where heroin works. That's where methamphetamine works. That's where cocaine works. That's where Valium, Xanax, the benzodiazepines work. They work in that part of the brain. This part of the brain is also the part of my brain that's key for survival. So that's where my blood pressure is controlled, my heart rate is controlled, my breathing is controlled, my temperature is controlled. So typically stroke there is fatal. Typically brain tumor there inoperable. So in that key survival part of my brain is where the addiction area actually lives. So the reason I start off this lecture just with a few minutes talking about that is that it's in this very central, deep-seated, primitive part of the brain. So I have raised 6 kids in Texas, so I know Texas better than any other state, but in Texas, for over 35 years, we've had the DARE program. So drug and alcohol education, every 2nd through 5th grader in Texas has a policeman that comes in, tells you all those kids, once a week or twice a month, all the terrible things that drugs and alcohol can do. My kids signed a contract. They wore little buttons home that said, "Just say no." It sounds great, but it's done absolutely nothing as far as drug use. If you look in Texas high schools, drug use has hardly disappeared with the DARE program. The thinking, that part of the brain actually where addiction takes place is in a different area. I could make anybody in this audience, I could make you a wager. If, for example, if you're over the age of, say, 40, if I give you 2 years to train and ask you to hold your breath for 5 minutes and 20 seconds, that's nowhere near the world record, but over 40, unless you've been doing that your whole life and you have 2 years to train, 2 years from now, I give you $10 million if you hold your breath 5 minutes and 20 seconds, you can't do it. So you train hard, underwater, breath holding, you do everything you can do for 2 years. 2 years from today, you come back to take me on my $10 million wager, but you can't make it, but you refuse to take a breath in. You've made 4 minutes maybe. But you just say, I'm going to take that guy's money. I'm not going to take a breath. What will happen? You don't die. You sit there by willpower. You choose to not breathe. What happens? You pass out. And when you pass out, what do? You breathe, right? So that survival part of the brain can actually supersede cortical function. You can't have the 3-year-old have a breath-holding temper tantrum because you didn't buy him toys in Walmart and they die in aisle 5 with a breath-holding spell. It doesn't happen. They turn purple, they pass out, they cry, they breathe. It's great. It supersedes that. So I just kind of start that because it's in a different part of the brain because if you're with me today, you're here because either you or one of your family members has tried and things are not going well, right? Somebody has told you just have to stop, you have to make this, you have to do the right thing. Roy Tarpley, you're making $5 million a year, it's in season, what are you doing? And yet here we are in Hunt, Texas. So let me go deeper. In the next slide, it's just a schematic of a brain cell or a neuron. And so if you look at that, it's got a main cell body called a soma, but then it's got all of these different little feelers or dendrites. So what that does is it enlarges the surface area of a brain cell so that every brain cell can be touched by up to 100,000 other brain cells, which are touched by, which are touched by, which are touched by, making my brain one of the most complex structures identified in the universe, and my brain's an electrical organ, so that information travels through that very rapidly. So I see a color, the color yellow on a shirt, it goes through my retina, back to my visual cortex. I process that information, I say the word yellow shirt, and thousands of different neurotransmissions just happen in my head. Very, very rapid. So we have the flow of electrical particles through these dendrites down the main branch called the axon, and then it gets to the nerve terminal. And at the nerve terminal, that's where the electric part stops. And then that's where neurotransmitters come in. So in the reward pathway, the epicenter of addiction, those neurotransmitters in the reward pathway are the chemical dopamine. So in this image, you can see this representation of the nerve terminal. And inside of that terminal, you see the little sacs. Those are called vacuoles. And inside of the vacuole, you can see the molecule dopamine. So the way the system is supposed to work is, when that part of my brain is stimulated, this chemical dopamine is released and it goes into the space. On the other side of the space, you can see the dopamine receptor. So, and kind of hang with me, I'm going to tie this together in the next few minutes. So dopamine gets on this receptor and it stimulates the receptor, and there's a chemical response that happens that I show you in this next slide. Now, I'm going to go back just to that dopamine receptor, and I want to talk about that reward pathway a little bit more. So I said it's the epicenter for addiction. It's where all of those drugs of addiction work, but what's it for, right? Surely the human isn't built for cocaine or methamphetamine or alcohol or cannabis. When I say the reward pathway, what is that for? That is the part of my brain where I experience reward, where I experience pleasure. So when I say reward, think about giving your dog a piece of bacon or something like that, where the dog is drooling and wagging his tail. For me, anything that you enjoy, that you're like, oh my gosh, that's amazing, that was beautiful, I love that. Anything that concept of pleasure, enjoyment, reward, that's where I experience that sensation. So that's what that part of the brain is for. So if I go back to this, the way it's supposed to happen is something stimulates my reward pathway, it releases dopamine, it gets on the receptor, stimulates the receptor, and that's when I experience pleasure. That's when I say I like it. So I venture to say that everybody watching me today probably had a major stimulus of your reward pathway, and that would be food. So I missed breakfast today at La Hacienda, beautiful spring day. I walk over to the cafeteria. We actually have, there's a hamburger with roasted corn, and I was hungry, and that thing when you're eating and swallowing and like, oh my gosh, that's good, and we all know, you know exactly what I'm talking about. That thing that you experience. In humans, take a hungry human, implant a microdialysis catheter into the brain of the hungry human, feed them, dopamine levels go up 100% in the reward pathway. Same part of my brain where my breathing is controlled, my blood pressure is controlled, my heart rate is controlled, my temperature is controlled. The key things that keep me alive, number one cause of death in the history of mankind, starvation and malnutrition, right? If I don't eat, I die. That makes sense to me, a critical thing. Peak natural is sex with orgasm, 150% increase in dopamine. No sex, no procreation, the species dies in 1 generation. That makes sense to me, right? But I also said anything I enjoy, a moonrise, a sunrise, a gorgeous hill country day. How does that correlate with survival, right? But take it to the extreme. What if you experience zero pleasure? What if there's not one touch of anything that makes you smile? Nothing that you look forward to? What happens to people that experience that? They commit suicide. They don't get out of bed. They don't function. They don't produce. They don't go to work. They don't. Those minor pleasures in life are actually drivers of human function. That makes sense to me. Okay. So I mentioned some numbers: 100% increase, 150% increase as far as that peak, right? But it's not dopamine that makes me say I like it. It's what dopamine does when it activates that receptor. So that's going to be important a little bit later in the lecture here. So we see this brain cell to brain cell communication. Now, until the late 60s, early 70s, still the leading concept on addiction really was stop. I mean, don't destroy your life, don't destroy your family, make the right decision. You're bright, you're motivated, you've done all of these things, do the right thing, right? And then really a game-changing animal study. And I'm going to reference that, and potentially if I have time at the end of the next lecture, I'll talk a little bit more about something that challenged it. But I think this initial study has incredible value. And it was very simple. What the researchers did is they took a cage, and if you put an animal in an enclosure, the animal explores the perimeter of the cage. Ranchers check their fence lines. If you have a dog in your backyard, you have a little groove, especially if you have like a chain link fence where the animals runs the fence line. If you've ever gone to a zoo, animals walk around, they check perimeters. So animals explore perimeters. So what they did is they took the initial study, they took laboratory mouse in a cage, they put food and water on one side of the cage. On the other side of the cage, they put a low, wide bar. Now, this bar was low enough and wide enough that as the mouse explores the perimeter of the cage, the mouse doesn't walk around it or jump it. The mouse always steps on the bar. They take the bar, they hook it up to a pump. They take the pump and they hook it up to an IV bag. So now I have a mouse hooked up to an intravenous catheter going into a large bore vein, hooked up to an IV pump, hanging on a swivel at the top of the cage, which gives the mouse freedom of access of the cage. Now, every time the mouse steps on this, the mouse gets intravenous that. It's just like a simple high school experiment. So in the research studies, if you put antibiotics, if you put blood pressure medicines, if you put heart medicines, if you put diabetes medicines, if you put any drug that we haven't seen patients abuse into this IV bag in this mouse model, this mouse ignores it, and this mouse just lives mouse in a box life, right? Ignores it. Change it. Let's put alcohol, ETOH, ethanol. Let's put pure alcohol into that bag. And now every time as the mouse explores the perimeter, he steps on the mouse gets intravenous alcohol. Within less than 3 days, this mouse acts like a lot of my La Hacienda patients in that this mouse loves to hang out at the bar. The mouse stays over here, they get drunk, they run over, they grab a snack, they run back, and they spend all of their time taking an intravenous alcohol. It's a mouse, right? Put other substances in there. Let's put an opiate in here like heroin. Now every time the mouse steps on the bar, he gets IV heroin. The mouse stays over here taking an IV heroin for hours and hours. Let's put a benzodiazepine in here, a medicine like Xanax or clonazepam. The mouse loves it and hangs out here. Let's put a highly addictive compound in here like cocaine or methamphetamine delivered via the intravenous route. With IV cocaine and IV methamphetamine, typically by the end of the third day, this mouse will no longer walk away. The mouse will stay and binges for hours and hours and hours and hours. Eventually exhausted, falls asleep at the foot of the bar, awakens, binges. In the initial study, it was an 18-inch walk to the food and water source, and these mice would die of dehydration and starvation. They wouldn't walk 18 inches. The food and thirst instinct in the animal kingdom are some of the most powerful survival instincts we know of. And here is food and water 18 inches away, and these mice died of dehydration and starvation. We had a crazy drought in the Texas Hill Country like 7 years ago or something. We didn't get rain up here for months and months and months. Animals smelling water, crawling through wooden fences to get to water. Take the nicest dog in the world and starve that dog. They'll claw through sheetrock to get to water. They'll bite your face to get food. They'll kill for food. And yet here's food and water 18 inches away, and the animal dies of dehydration and starvation. This study is fundamental in addiction medicine. And typically they talk about two different things. I'm going to mention a third that I think is very profound. Number one is, it was the first time that we could objectively identify, does this drug change animal behavior? Is it reinforcing? Simplistically, is it addictive? So if I put antidepressants like Prozac or Zoloft or Lexapro in there, the mouse doesn't care. But if I put a compound like these, and it's the exact same thing that we saw in our patients. So it was the first time we could objectively say, yes, but Dr. Boone, I think if I take benzodiazepines, it's okay. Well, we don't see that in all of our patients. We don't see this in the animal model, an objective measurement. Number two, specifically with cocaine and methamphetamine, when these animals actually died as opposed to seeking out food and water, it was also sort of completely surprising information, unexpected by the researcher. The power of that, wow, that doesn't make sense. When I give this lecture to our patient population here at La Hacienda, I cover a lot of information. I don't take time for questions during the lecture, but it's not uncommon that a patient will stand up or raise their hand and go, hey, Dr. Boone, I did IV methamphetamine. I still got something to eat or drink. I'm like, I know, that's great. You're smarter than a mouse. I'm proud of you. But at the same point in time, you were injecting something where somebody died of an overdose 2 weeks earlier. You buried a best friend with heroin and you're still injecting heroin. You were picked up on I-10 West going eastbound in a blackout from alcohol and Ambien. I mean, who's the crazy? I mean, it was just the first time that we could sort of looked at this and went, man, what is that? This is a powerful, sort of surprising and shocking finding. And then the third thing for me that was actually very profound about this study, for me, it was also the first time that it's separated from the moral equation. Because nobody's going, well, yeah, but you're a bad mouse, or you need to get some good mouse friends, or go to mouse church, or some, I say that facetiously, but I'm serious at the same time, is that it was the first time that it's separated from the moral equation. So then technology was getting better, and so we initially had the intravenous catheter into the mouse, and then the researchers are going, okay, but where does that take place? Could we implant a microcatheter? So they then took a microcatheter and put it directly into the brain of the mouse under CT or MR imaging. And when we put a microcatheter, I can deliver drug that goes less than 0.5 millimeter from the catheter tip. So in the next image, for example, I can see here this image of the brain, and in that reward pathway, I've got some fancy doctor words here. VTA stands for ventral tegmental area, nucleus accumbens. This reward pathway, if I put drug here or here, that animal is addicted. If I put that drug and I put heroin somewhere else up in the cortex, in the posterior area, higher up in the thalamus, in the frontal lobe, I put heroin directly into the brain, what does the mouse do? Nothing. The mouse ignores it and explores the cage until I put it in that reward pathway, animal instantly addicted. So it allowed us to go, okay, so that's where addiction is taking place. Then the researchers started to think, okay, if the brain's an electrical organ, what if we bypass drug altogether? So let's actually remove the catheter. Let's make this a battery. Let's implant a microfine coated electrode, and let's deliver milliamperage of current directly into the brain of the mouse. Deep electrical brain stimulation. So in this next image, you can see I can take that electrode, and if I implant that electrode into the reward pathway, this mouse quits eating, quits drinking, and electrically stimulates the reward pathway till they die. Very potent, very specific area. Then as technology was advancing, we were able to label compounds. So in this next image, what we see is, you can see on these tiny green dots, this is where this brain has been labeled for cocaine. So we've labeled cocaine, and then via neuroimaging technique, we can see where cocaine is concentrated. And where you see cocaine concentrated, right here in the middle of the brain, this big kind of green area, that's called the prethalamic stripe. There are other names for that, but that's one of the areas it's called. That part of the brain is responsible for mindless repetitive activity. So by mindless repetitive activity, think about walking. When you walk, nobody thinks about, oh, I forgot to do my left foot, right foot. You just walk, you don't think about it. When you eat, nobody ate lunch today and forgot to open their mouth. You eat, you chew, you swallow, you breathe. You can stop any of that at some point in time, but that takes coordination by the prethalamic stripe. As they begin to study all of these drugs of addiction, all of the drugs of addiction, from cannabis to opiates to stimulants to alcohol, they all stimulate the prethalamic stripe, stimulate mindless repetitive activity. Methamphetamine and cocaine, recurrent picking at the skin, picking at the face, pulling of the hair, recurrent paranoid looking through the blinds, but also mindless repetitive activity. The next thing you know, you're driving to the liquor store, you're calling the drug dealer, you're pulling out looking for a pill. Mindlessly automated, that's stimulated by the drug itself. But that in and of itself is not enough to make it addictive. It was so profound, they went back to the mouse and they're like, hey, did we miss something? And so if I just put cocaine into the reward pathway, the mouse actually doesn't get addicted. So it's what happens in the reward pathway. And you can see the concentration in the reward pathway. And in the reward pathway, brief reminder, right, I mentioned at the beginning of the lecture, so food 100%, sex 150%, dopamine activates the receptor, falls off the receptor, taken up by the protein transport pump back into the cell. That's how the system is supposed to work. So food, when I had a little bit of dessert at lunch today, I was wishing I hadn't eaten that 10 minutes later. It doesn't last very long. It's like, oh my gosh, that's so good. And 10 minutes later, I'm walking out going, shoot, I wasn't going to eat dessert today, right? So it's very intense, but it doesn't last very long. Sex, very intense, doesn't last very long. Dopamine falls off the receptor. So that's how the system is supposed to work. Cocaine comes into the reward pathway and it blocks the reuptake pump. So you can see this structure. So cocaine blocks the reuptake pump. So I get delivery of dopamine into the reward pathway. It activates a receptor. It falls off. It activates it again. It falls off. It activates it again. It activates it again. It activates it again. And I have up to 300% increase in dopamine in the reward pathway. Peak natural is 150%. So if I have peak natural of a 150% increase in dopamine, I have 300% surges. With intravenous methamphetamine, this number may go up as high as 1,100% increases in dopamine in the reward pathway. This is my pleasure center. So 16 years ago, when I first heard this data presented, I'm this guy that I don't like the taste of alcohol. I've never used an illicit drug. I'm sitting in the audience listening to that data and I'm thinking, food 100%, sex 150%, 300% of my pleasure center, 1,100% of my pleasure center. I'd love to try that, like sign me up. Until minutes later in the lecture, the data was explained further. Here's the problem. The problem is that my brain is built for a 150% peak surge. It's like operational parameters. If I get a brand new computer in the US and it charges with a 110 volt, I travel to Europe that has 220 volt, and I'm like, don't tell me what to do with my computer. If I can plug it into that outlet, I'm going to blow it up. It's built for 110, not 220. My diesel Jetta that gives me 50 miles to the gallon, that's a standard. If I say I'm not shifting out of third gear, I'm putting jet fuel in this and it's going to be amazing. No, it's not. It's going to blow up or not work. It's built for diesel. It's built to shift. My heart only goes so fast before I die, so slow before I die. My eyes can only handle so much light intensity. The solar eclipse, 2.5 years ago or whatever, I mean, if I had a patient that said, Dr. Boone, I'm not going to wear those little silly glasses. I want to look at it. Well, you can, but you'll have central blindness the rest of your life. Your eyes aren't built to handle that light intensity. So, my brain is built for a 150% peak surge. So, I take it up to 300%. So I take one line of cocaine, I get a 300% surge in dopamine. then what happens is, and this is a little simplistic, but if you look in this view on this slide, what you see is you see 5 of these dopamine receptors. And simplistically, I get 300% surge of dopamine, but it's not dopamine that makes me say I like it. If you recall, it's what it does to the receptor. So simplistically, I desensitize a receptor. So now, for example, instead of 5 of these receptors that all produce this chemical response that make me say I like it, only 4 produce the response, and it wasn't quite what I remember it. So that's the phenomenon of tolerance. So you got a high with a little tiny bit of cocaine, and then the next time you try it, it's not quite what you remembered it, and it's not quite, and you take a little more and a little more. And you got a buzz with 2 beers, and then it was 3, and then it was 4, and then it was 6, and then it was 8, and now you're drinking vodka, and now you're drinking whatever, heroin. First it was a little hydrocodone, and then it wasn't quite what it was, and then you buy oxycodone, and then heroin's cheaper than oxycodone, and you chase. So it's the phenomenon of tolerance. But what else does that mean? This is where I experience pleasure. This is my reward pathway. This is where I experience the concept of pleasure, of laughter, of enjoying the simple things. So I sat in that lecture going, oh my gosh, I'd love to know what that's like, to all of a sudden going, oh, I want a moonrise, I want a sunrise, I want to enjoy time with my wife, a great cup of coffee, playing with my kids, with my grandkids, going on a fishing trip, just those things that bring me joy and pleasure. I'm like, I want to feel all that. And what happens to my patients who are using substances? Because I've mentioned these high surges, but all of the drugs of addiction take me over this 150% threshold. So it depends on how high I go over it, like my drinkers, depending on how often I go over it, how high I go over it, what the half-life of the drug is. How long does that drug stay in my system and suppress that? I desensitize those things. And so what do I see with my patients? They begin to lose the simple pleasures of life. Hobbies and all of those things that used to give them laughter and joy, and now it's a little bit boring, it's a little flat. I need a drink to go with this. I need to smoke to go with this. And they continue to desensitize that ability. Now, good news and bad news. The good news is that over time, you will restore your dopamine receptor population. The bad news, it's typically around 6 months. So at La Hacienda, most of our patients stay 3 to 5 weeks, maybe a little bit longer, but it's almost never that we have somebody that stays 3 to 6 months. But patients, family members recognize there's time. You have to give your brain time for recovery. And so by the 3 and 4 week mark, you get more rapid recovery during the first month. You get gradual recovery of those dopamine receptors. So commonly by the end of the 3rd week or 4th week, I'll hear my patients laughing in the waiting room, or they'll be saying, oh my gosh, I haven't laughed that hard in X amount of time. They're starting to feel things, but there's going to be something that they might do that they did with alcohol on board, that they did with cocaine on board, that's not going to seem the same. Because they have to give time for their brain to recover, time for those dopamine receptors to recover. Now, the other thing that happens is that you can see in this next slide, you can see that there's this feedback loop. So at the beginning of the lecture, that prefrontal cortex that has judgment and reasoning, that's the part of my brain where I have the ability to have judgment. So for example, my example today of eating a piece of cake at lunch, my concept was of like, oh my gosh, I really shouldn't eat that, but then I'm just going to eat a little piece. I'm still 7 or 8 pounds overweight from Christmas and Thanksgiving, and it's mid-May. I need to walk out of the cafeteria, but instead I ate a little bit. But it's that thing that we all do of, gosh, I'd love to, I probably need to. Hey, let's get I probably should. What you're doing is that is prefrontal cortical reasoning that allows you to have that risk-benefit, what we call executive reasoning, top-down sort of level of judgment. Now, what we know in 2007, the first data came out that all the drugs of addiction actually damage the neural pathways. So that connecting fibers, that gets better in 90 to 120 days. Probably behind one of the traditions in AA of 90 meetings in 90 days, or of how dangerous it is that first few months. And it's very dangerous. Risk of relapse is very high during those first few months. And why is that? Because impulse control is impaired. They don't have the ability to have instant feedback from their prefrontal cortex. The second thing, and where there's a great deal of research and study being done, is that all the drugs of addiction actually damage the prefrontal cortical structures themselves. So if we do volumetric MRI, where we can actually measure the size of brain structures, and I measure the actual size of the prefrontal cortical structures in a heavy drinker, drug user, compared to somebody that does not use, my prefrontal cortex larger, more robust, more functional than my patients. Good news and bad news. That also recovers, but it takes time. So we see significant recovery during the first month, but based on what are called blood flow studies. So if my eyes are injured by smoke or chlorine in a swimming pool or whatever, my eyes are red, my body is dilating blood to bring more blood for healing, bring more oxygen, bring more nutrients. I had bilateral knee replacement a couple of years ago. Both my knees stayed slightly warm for months. And why was that? Because my body was sending more blood to heal that implant site. Heavy drinkers increase cerebral frontal blood flow for 3 years, 4 years in some studies. Continued recovery, continued improvement, that time for ongoing recovery. So for me, it's not bad news. It's not, oh my gosh, I'm going to be terrible for 3 years. No, because so many of my patients are dramatically better at the 1 month mark. Dramatic improvement. But I'm able to look at them and go, hey, it's going to be better. In 3 months, it's going to be better. In 6 months, it's going to be better. In a year, it's going to be better. In 2 years, it's going to be better. Time, give that brain time for recovery, for healing to take place. This next image actually looks at brain function. So this is done with SPECT or PET scanning. You can do it with functional MRI. So in this image on the far left, you see what's called normal function. And I'm going to briefly just draw 3 images on the board. So there was a fascinating study done by NIDA, National Institute on Drug Abuse. And the first image was just a normal patient with no drug exposure. And normal function, when we label glucose, which is the fuel of choice for the brain cells, when it's utilized, it's red in high concentration, high utilization. So you can see throughout that brain image, there's red and yellow is slightly lower. In the middle, you can see purple. That's the fluid-filled ventricles, and purple around the outside, fluid around the brain. No glucose utilization. Normal. Now this one image on the right is done with cocaine, and you can see that there's not nearly the same amount of red coloration, the actual brain function and utilization impaired. But in a NIDA study, this is the front part of the brain, the way this image is done, the patient laid on their back. And in the NIDA study, 10 days after cocaine, 10 days. Now, cocaine was used in this study because 10 days after cocaine, there's no evidence that there was ever any cocaine in your system. And 10 days later, immediately after the glucose infusion, the frontal area of the brain is essentially purple. That is the area of my brain that gives me impulse control, instant decision making, profoundly impaired. 100 days later, 100 days after cocaine, there's patchy recovery. 180 days, it's basically back to normal. Again, nobody stays for 180 days. Give time, go the extra mile. So commonly, as patients are getting ready to leave treatment, we're talking about aftercare plans. What do you need to do? And so commonly, it's not recognized how dangerous these early times are. And it's not dangerous because your heart isn't right. It's not dangerous because your commitment to recovery is not right. That you want to do the right thing. You want to love your family well. You want to not drink. You want to not use. I get that. But the problem is you can't trust your head. Your brain is not fully recovered. So there may be extra things you need to do. Do you need to look at a sober living arrangement? Do you need ongoing individual counseling? Do you need an extended aftercare program? Do you need to look at relapse prevention medications as an added tool that can help with alcohol or help with opioids, the medication-assisted therapy? What do you need? You need some extra help. And again, not because we don't think that your desire is right, but it's just because your impulse control, the way your brain functions, is not normal. Move away from stimulants into opioids. If you look at the opiates, so opiates are oxycodone, heroin, hydrocodone, codeine, unfortunately the medication tramadol, which is an opioid. But if you look in the brain, you can see concentration up here in the cortex, that outside part of the brain, the high functioning part of the brain. So we've known for decades and decades that if patients take too much opioid, they become cortically impaired. So as an internal medicine physician, multiple elderly patients who had surgeries and pain medications put them at higher risk for a fall, or they become what we call cortically impaired. That's been known forever. So we see these opioid receptors. We see receptors there in that prethalamic stripe, do the same thing over and over again. Receptors in the reward pathway, and then also concentration in the midbrain. Now I want to go back to the top, to the cortical area just for a minute. So this was so fascinating to me. I'm a well-trained internal medicine doc. I go into practice in Waxahachie, Texas. And shortly after I go into practice, I'm taking care of a young man at a small college there in Waxahachie, Texas, who's a soccer player. He injures his knee badly. There's no orthopedist full-time in Waxahachie back in those years. So he comes in my office to see me, and he's got this horrifically swollen knee, poor range of motion. I'm like, oh boy, you've got a bad injury. I don't think you broke anything, but you've got some major tears in your knee. I actually drained some blood out of his knee. I put him in a knee immobilizer. I gave him a prescription for hydrocodone, Vicodin extra strength back in those days, pre-generic, and ordered an MRI of his knee and asked him to come back to see me the following Tuesday. So this young man goes home, he gets his MRI on Monday, he comes back to see me the following Tuesday. I've got his MRI report, bad tear, he's gonna need surgery. And I'm talking to the young man, I'm like, hey, how are you doing? He's like, I'm okay. How are you doing pain-wise? He goes, I'm doing okay, the medicine helps. But then he looked at me, he goes, hey, Dr. Boone, those pills you gave me, I feel great when I take those pills. I look at him like, what do you mean you feel great? And he goes, I don't know. So I've never had anything like it before. I don't even know what to tell you. I'm like, well, what do you mean? And while I'm asking him that, I'm thinking about my own experience. I had recently torn a meniscus. I had an arthroscopic repair of my knee. I had a prescription for hydrocodone. They made my mouth a little dry, a little constipated. I got 20. I think I took like 7 tablets. And he goes, no, I feel great. And I'm like, what do you mean you feel great? And he goes, wow, I don't even, I had a test to study for this weekend. I did great on my test yesterday. I have more focus. I have more energy. I feel better. And I looked at him, I'm like, oh my goodness, they gave you the wrong medicine. He's describing this energized, stimulated experience. I'm like, hey, do you have your bottle? He goes, yeah, I got it right here. He hands me the bottle. It's got his name, Vicodin ES, written on the bottom. I'm like, there's no way. I open the lid. I pour one on the desk. Little tiny yellow tablet used to have Vicodin ES written on the tablet. I'm looking at that. I'm going, these? He's like, yeah. And I'm pondering, like, what in the world? And he goes, can I have more of those? I'm like, no. And I put that tablet back in the bottle. I put the lid back on there. I don't think about that for the next 20 years of my career as an internal medicine doc. What he was describing was something that I don't have. No addiction in my own life, no family history of addiction. This young man at that point in his life, no history of addiction in that young man. And his experience was this biphasic response, that his initial experience with opioids is that he's cortically energized, he's stimulated, he's motivated. Everyone in this audience that's been an opiate, that struggled with opiates, knows exactly what I'm talking about. You take opiates, you function, you go to work, you're more alert, you're more attuned, you have this energized response. But there's this fine line when all of a sudden at this peak sort of energized and euphoric experience, the euphoria comes from where it kicks in on those reward pathway receptors, then all of a sudden it goes the opposite direction. And it suddenly plummets down and you become cortically impaired. And not only you become cortically impaired, we look in this area, that prethalamic stripe, do the same thing over and over again. But right there in the midbrain, those other areas that are highlighted, what lives there? That's where my pain fibers live. That's why opiates work for pain. It's a survival mechanism. But what else does it affect? It affects my breathing. That's where my breathing is controlled. So in 2018, we had 115 accidental opioid overdose deaths a day in the United States. We're in the height of the opioid crisis right now, right? And why do opioids kill people? They kill people because they shut the respiratory drive down. So not only do I become cortically impaired, but then that part of my brain that senses drops in oxygen levels and increases in carbon dioxide that makes me breathe, that's blocked by opioids, and people then die a respiratory death. But what makes them addictive? Back to this next slide, here in the reward pathway, here in the reward pathway, I have an opiate receptor. I have a specific receptor in my head that responds to heroin, to oxycodone, to hydrocodone. Why? Why do I have that? What is that for? That also led to the Nobel Prize in that my brains make a natural compound called the beta endorphins. So that's actually a beta endorphin receptor. What is the major stimulus of beta endorphins? Hard physical exercise. 45 minutes sustained heart rate elevation. I get a beta endorphin surge. It stimulates that reward pathway, the concept of the runner's high, that increased sense of well-being. But think about it. If I'm in better shape, I get away from the predator. I work for longer. I work harder. That makes sense to me. Sex, little beta endorphin surge, procreation, survival of the species. Certain high-calorie foods, little beta endorphin surge. If in the history of man, not in 2020 in America, but in the history of man, if it was starvation, high-calorie foods, I get that. That makes sense, a little beta endorphin surge. But what happens is that opiates come in here, they hijack my beta endorphin receptor. It's called a neuromodulator. So in this image, you can see those 5 dopamine receptors, but when that opiate receptor is stimulated by a potent opioid, it modulates the response, and it feels like I've got about 200% plus increase in dopamine activity, which then gives me the euphoric response. I then start to get the same damage to the neural feedback loops, decreased ability to have impulse control, judgment, damage to the prefrontal cortical structures. Opioids. Now I'm going to close today. In the next lecture, we're going to talk about marijuana, we're going to talk about alcohol, and we're going to talk about the relapse pathways. I know it's a ton of information, but I'm so glad that you're here and hope that this is going to be helpful. Thanks.